Hello, my name is Paul DeBeese. I'm a board member of the Massachusetts Citizens for Life, and I'm your host for this evening. The debate over abortion pill rescue has become a front line in the battle to protect life. APR places a spotlight on the health and well-being of the mother and on her preborn child. The evidence shows that APR is safe and effective, but the attacks on APR treatment and on the clinicians that provide APR treatment is growing. Our speaker this evening will help us cut through all the noise and separate fact from fiction. I am honored to introduce Dr. Christina Francis. Dr. Francis is a board-certified OB/GYN who practices in Fort Wayne, Indiana. She completed medical school at Indiana University in 2005 and completed her OB/GYN residency in 2009. She is a board member and CEO of the American Association of Pro-Life OB/GYNs and associate scholar with the Charlotte Lozier Institute, a board member of Indiana Right to Life, and a physician member of the Abortion Pill Reversal Network. As a pro-life speaker, Dr. Francis offers her medical expertise, knowledge of bioethics, and her pro-life reasoning. She has always had a passion for human rights, working for 3 years as the only OB/GYN at a mission hospital in rural Kenya, until returning to the United States in 2014. She has written on issues surrounding women's health and abortion for publications including The Wall Street Journal, Newsweek, and USA Today. Dr. Francis, I've so been looking forward to hearing you speak. I'm going to turn it over to you and then come back when it's time for Q&A. Off to you.
Thank you. Thank you, Paul, and thank you, Massachusetts Citizens for Life, for having me on. And thank you to all of you who are joining us tonight. I know that for many of you who are pro-life and are a part of this fight to defend life, you're doing it maybe in an environment that isn't always so friendly. So I just want to encourage you to continue your fight, and hopefully this will be educational for you. And even if there's some people joining who maybe aren't pro-life, who joined out of interest, I hope that you will realize that abortion pill reversal really is about providing choices for women and a chance to save their child when they desire to do so. So I'm going to attempt to share my screen here, and I think for the host, it's not letting me share my screen. So maybe we can get that fixed, and then I will get my PowerPoint. Here we go, up here for you guys. All right. So I'm going to jump right in. As Paul said, I am CEO of the American Association of Pro-Life OB/GYNs, and we are a professional medical organization that represents almost 7,500 medical professionals now from around the country who desire to practice medicine from a life-affirming standpoint. And one of our big missions and goals is to provide the evidence base that our members need in order to practice life-affirming medicine and to defend that practice. And one of the big issues that we have seen, as Paul said, especially in the last couple of years, is that the really miracle of abortion pill reversal or abortion pill rescue has come under attack. And one of the things that has been said is that there's no evidence to support it. And so I hope that you'll leave here tonight understanding that there really is a lot of evidence to support the use of this treatment, and that it is safe for women and should be an option available to women who decide that they regret their choice to start a chemical abortion. So we're going to jump in. So a lot of this will be about abortion pill rescue, but I think in order to fully understand that, we really have to understand chemical abortion first and foremost. And so let me see if I can get my, there we go. And so, when we talk about chemical abortion, this really has become sort of the new frontier for the abortion industry. And we've been working up to this, but certainly in the last few years, we've seen a huge increase in the number of chemical abortions. The Guttmacher Institute, which is a pro-abortion Research Institute, in their latest numbers, say that close to 60% of abortions are now completed via the chemical abortion process as opposed to surgical abortion. And so it now is more common than surgical abortions. And we really are seeing kind of an exponential increase in the percentage that are done via drugs as opposed to via surgery. And I think we're only going to continue to see that increase over the next few years. I think the reasons that this is increasing are numerous. Many women see it as easier, perhaps because it's not a surgery. Maybe they see it as safer because it's not a surgery. They see it as more private. That's certainly how it's marketed to them, that it can be done in the quote unquote safety or comfort of their own home. But really, as I think you'll see, it really has been the great deception for women that this is a safe procedure. First of all, it's not. It is more dangerous than a surgical abortion for the woman. Certainly is just as dangerous as a surgical abortion for that preborn child whose life will be lost. And it's also very emotionally and mentally traumatic for women. And it turns their home into an abortion facility as opposed to maybe a separate, where they would go to have a surgical abortion. That's a separate facility that they can avoid then for after the point that they have their abortion. And many women say that they avoid that. But now we're turning women's homes, their dorm rooms, their bathrooms into abortion facilities. So this really takes a significant toll on women. And again, it's not safe. These drugs have a black box warning attached to them. They had special regulations put into place when they were approved, and we'll talk about that a little bit. But again, I think we need to be very clear what we're talking about when we're talking about chemical abortion. So it's a very specific 2-drug regimen. The first of which is called mifepristone. You might have heard that referred to as RU486. That's how it was referred to when it was first approved. And then a second drug called misoprostol, so 2 M words. And that second drug is taken 24 to 48 hours later. And we'll talk about what these drugs do and the process, because again, that'll help us understand the process of abortion pill rescue. These drugs, for the purpose of induced abortion, were originally approved in 2000, and they were approved up to 7 weeks gestation or 7 weeks of pregnancy. In 2016, that approval was expanded to 10 weeks of pregnancy, and that's where that gestational age cutoff is where it has remained since then. It's important to remember this is not the same thing as Plan B or the morning after pill or emergency contraception. Those are different. That's not what we're talking about when we talk about chemical abortion. We're talking about these 2 very specific drugs used in combination with one another. And so again, let's talk about how this works. This is a picture of a uterus here. And the first drug, mifepristone, works by blocking the action of progesterone. Many of you have probably heard of progesterone. It's a crucial hormone in early pregnancy, and you can see here what it does for that developing preborn child. It prepares the lining of the uterus for implantation. So once the embryo comes into existence, a few days later, it travels down the fallopian tube, and a few days later, it implants into the lining or the wall of the uterus. And progesterone is crucial in prepping that lining of the uterus to be a hospitable place for that embryo to implant. After that, then it promotes the development of the maternal, or the mother's side of the placenta. The placenta is an organ that develops, starts kind of kicking into its full function at about 12 weeks of pregnancy, that then will go on to nourish that baby, of course, for the duration of the pregnancy. Progesterone also inhibits uterine contraction, so it prevents the uterus from contracting, especially early in pregnancy. And so how these drugs work, mifepristone binds to the receptors that were meant for progesterone and blocks the action of progesterone. You can think of it like a key that fits into a lock, but it won't turn the lock. So it binds to that receptor and it blocks the ability of progesterone to bind and then initiate all of these actions that it's supposed to do for that early pregnancy. And so by blocking progesterone, then it leads to what's called necrosis, or breaking down of those connections between mom and baby. And essentially what that leads to is starvation. So it cuts off the flow of nutrients, and also suffocation. It cuts off the flow of oxygen to the baby. And so most times just that first drug will lead to the death of the baby. And then that second drug, the misoprostol, that a woman takes, that essentially induces labor. So it makes her uterus contract and expel the baby, who, again, almost always has already passed away. If not, then would pass away during that labor process, and along with the early placenta and any other pregnancy-related tissues. So the symptoms that women feel or go through, experience when they have a chemical abortion, you can see them listed here. Sometimes they're mild, but sometimes they're very severe. So women will have a lot of pain, which is usually accompanied by significant nausea and vomiting. They'll have a lot of vaginal bleeding. They're told to just expect kind of a heavy period. This is not like a heavy period. On average, women will bleed for about 2 weeks, but you can see here, almost 10% of them will bleed for longer than a month. And so this is a significant amount of bleeding that women experience, which is why if they are anemic, that's actually what we call a contraindication, or a reason why women should not take these medications. If any of you saw the movie Unplanned, Abby Johnson's movie, I think they actually did a very good job in that movie of showing what women experience when they have a chemical abortion. We also know that they experience significant complications or adverse events. So we know that the adverse event reports that are filed with the FDA are significantly underreported. It's likely, according to several studies that have looked at this data, likely capturing less than 6% of all complications. But there are more than 5,000 filed with the FDA. And actually, I should have updated this slide, unfortunately, because there's been, since I put this slide together, there's been a couple other deaths that have been reported. So we're up to about 30 deaths now reported related to the use of these drugs, including a woman just recently in Las Vegas who died from sepsis related to blood infection. Other adverse events that women experience are hemorrhage, or really, really heavy bleeding that may require a blood transfusion, infection, an incomplete abortion where they don't pass all of the baby or all of the pregnancy tissues, or even undiagnosed ectopic pregnancies. That's kind of outside of the topic of today's talk, but this is a real danger. Ectopic pregnancies still can kill women if they're not diagnosed quickly and taken care of quickly. I just wanted to go through, I don't want to get real technical with the studies, but just so that you know, I'm not making this up about the complications that women face when they complete a chemical abortion. There are several studies that look at this, but one of the really big ones was out of Finland, and it looked at over 42, almost 43,000 women who had chemical abortions versus surgical abortions, and they looked at the complication rates. And they followed them out for 6 weeks after their abortion. What they found was that the overall incidence of complications or adverse events was actually 4 times higher with medical or chemical abortions compared with surgical abortions. So again, I think a lot of women think that surgery must be more dangerous than a medication. But in fact, chemical abortions are 4 times more dangerous for women than our surgical abortions. And yet these are, again, accounting for an increasing percentage of the abortions in this country. So what they found was with chemical abortions, 20% of patients, or 1 in 5, experienced a complication, versus with surgical abortion, it was basically 1 in 20. So there you can see about a 4-fold increased risk. What they found was that about 15% of women experienced hemorrhage or very heavy bleeding. About 7% of women had a retained tissue, which would mean that they would need to have a surgery then to fully empty their uterus. Otherwise, they're at risk for hemorrhage and infection. And they found that 6% of women needed emergency surgery when this was done in the first trimester. But when women took these drugs in the second trimester, that increased to 40% of women needed a surgical completion of their abortion, which is significant when you know the way that these drugs are being dispensed now, which again, we'll get to. Another study showed a 500% increase in ER visits related to chemical abortion. You can see there between the years of 2002 and 2015. And again, chemical abortion visits to the emergency room were much greater than surgical abortion visits. So they're causing a lot more complications. A lot more women are having to go to the emergency room to be evaluated. So you can see here, for every 100 abortions, they found that 35 women had to go to the emergency room. Now, women are being told that these drugs are safer than Tylenol. I don't think 35% of people who take Tylenol show up in the emergency room. So this is a blatant lie and a deception for women. There are some long-term complications as well. And again, I think it's important to go through these because this is even another benefit of women not completing a chemical abortion, is they can avoid many of these complications. So one of the long-term risks of abortion in general is an increased risk of preterm birth in future pregnancies. There's more than 160 studies that have shown this. And this was thought to be mostly due to surgical abortions because of damage to the woman's uterus and her cervix from the surgery. But the highest risk group is actually those women that start their abortions chemically and then have to have them completed surgically. Those women have a 300% increased risk of preterm birth in future pregnancies. And the more abortions they have, the higher their risk in future pregnancies. And this is a real problem here in the US even. We have a ridiculously high preterm birth rate for a developed country that we have not been able to decrease over the last few decades, despite numerous attempts at interventions for risk factors. But I think that one of the reasons we haven't touched it is because we're not touching this risk factor, the risk factor of previous abortions. We also see an increase in adverse psychological outcomes. So we know that abortion in general causes a 6 to 7 times increased risk of suicide for women. But also, again, with chemical abortions, they are very unique in a couple of ways. One, there are some studies that show that the drug itself, mifepristone, actually causes an increased risk of depression because of its effect on the body. But also, women are then passing their babies at home and they're seeing their babies. And many women that I've talked to and that partners of ours have talked to have said that they were not prepared for seeing their baby after they had a chemical abortion. And so this causes significant, again, mental and emotional trauma, leading to an increased risk of depression, anxiety, substance abuse, and suicide, unfortunately. Now, the history of mifepristone, the drug that causes this, is a very sordid history, actually, that many of you might find interesting to read. I would encourage you, if you want to know more about this, to go. AAPLOG is one of the plaintiffs in the case against the FDA over this drug, over their illegal approval of this drug. And Alliance Defending Freedom is representing us along with 7 other plaintiffs. And actually recently some states have joined the case as well. And so you can go to ADF's website and if you just search on their website, FDA, you'll come to the case page and you can read there more about the history of how mifepristone was approved. It really is a travesty for the safety of women and girls in this country. And the FDA, in addition to their illegal approval of this drug, because they ignored their own safety regulations, they have continued to endanger the lives of women and girls across this country with what they've done. So I won't spend a long time on this slide, but you can see here sort of the path that this drug has taken, allowed by our FDA over the course of its lifespan here in the US. So again, in 2000, it was initially approved through a rapid approval process. So they were able to skip several steps along the process because of going through this rapid approval process. They had to label pregnancy as an illness in order to approve it in the way that they did. But when it was originally approved, again, it was approved through 7 weeks of gestation. Women had to have several office visits. It had to be dispensed in person. All serious complications had to be reported to the FDA. Then in 2016, they instituted the first major changes. They expanded it to 10 weeks, dropped the office visit to only 1, said you don't need to come back for follow-up after this to ensure that you actually did pass everything so that you don't have complications. They said that any prescriber can prescribe this, so it didn't have to be a physician. And at the same time as they did all of these things that they knew would increase the risk of complications, they said, you no longer have to report complications. Now you only have to report deaths. And then in 2021, the FDA removed the in-person requirement, meaning that now these drugs can be dispensed online, they can be delivered via mail. And then in 2023, the FDA said that these can be dispensed at your local CVS or Walgreens. And so each of these steps you can see was all about expanding, quote unquote, access to chemical abortion, but really was about endangering the lives of women and girls because essential safeguards were being removed at each and every step. And again, I'll go through this very quickly just because I want to get to the abortion pill reversal, but I do think that this is important to understand. This is all a part of the same subject, the same important topic. The in-person visit requirement especially was very important because this was crucial for minimizing the risks to women from mifeprex, that's the brand name, or mifepristone. We know that the risk of complications related to this drug is directly related to how far along in pregnancy she is. The farther along in pregnancy she is, the higher the risk of complications. As I said, in the second trimester, 40% of women will need a surgical completion. We also need to know exactly what drugs are being dispensed. Many of these drugs that are ordered online now are dispensed from pharmacies in India. We have no idea what's in them, whether or not it's the actual drug mifepristone, whether other things are in that. Also, the medical support setting in which the chemical abortion takes place, this ensures appropriate follow-up and the availability of surgical intervention if necessary. It also allows us to be able to screen for ectopic pregnancies, to be able to screen for coercion or abuse. None of this can be done when a woman is not being seen in person. All right. So now let's get to the important part. Let's get to the silver lining of all of this. So I always like to leave people on a positive note. I've shared a lot of depressing news with you, and now hopefully I can share a little bit of hope. So the one, I guess, silver lining to the percentage of abortions being done with these drugs increasing is that women have an opportunity, if they change their mind after they start the abortion process, to reverse that process and to try to rescue their child and save their child's life. And that is through like I said, I really think miraculous, but also basic treatment involved with abortion pill reversal or abortion pill rescue. This is about providing choice for women. Why would we not, again, regardless of where someone stands on the issue of abortion, if a woman says, I made a mistake, I chose the wrong thing, I desperately love my baby, why would we want to deny her that opportunity? And yet those who are opposing abortion pill reversal, that's exactly what they're doing. And I can't take credit for this line. I heard somebody else say it, but I think it's so true that when we deny women the opportunity for abortion pill rescue who want it, who want to save their child, it's essentially the same thing as forcing them to complete an abortion that they no longer desire. And, if you look at the polling results from across the US, very, very few people, if any, are in favor of coerced or forced abortions. And yet, when we deny APR to women who want to save their baby, that's exactly what we're doing to them. But it's really important that women know about APR actually even before they start the process, because time really is of the essence. They have to start the process before they've taken that second drug, the misoprostol. And the sooner they start the reversal or the rescue process after taking mifepristone, the first drug, the higher the chances of success. So women really need to know about this when they're going to obtain the chemical abortion, or just in general, they need to know that this is an option for them. So I think to a lot of people, it sounds a little crazy that you could reverse a drug like mifepristone, but you can. And it uses a very basic fundamental principle from biochemistry. I don't know if I have any science geeks out there, but if you took biochemistry or even just chemistry in high school or college, you might remember learning about something called competitive inhibition or reversible competitive inhibition. Basically, what this means is if you have a substance like mifepristone that is meant to compete with another substance like progesterone, you can outcompete the competitor, the mifepristone, by adding more of the substance that it was meant to block, progesterone. This is something that's used in many aspects of medicine, actually. So one of the areas in medicine that we use this is when people have carbon monoxide poisoning. So carbon monoxide binds to a receptor on a red blood cell meant for oxygen. And so it blocks the ability of that red blood cell to carry oxygen. What's the treatment for carbon monoxide poisoning? Oxygen. And it's the same principle. It outcompetes the carbon monoxide and then binds to the red blood cells and oxygenates then the person's body. And you give it in high doses in order to be able to outcompete the carbon monoxide. So that's exactly what we're doing with abortion pill reversal, but we're just using progesterone to outcompete the mifepristone. And the fact that mifepristone can be reversed by progesterone was actually confirmed by the manufacturer of mifepristone by their own studies. it showed that mifepristone is a reversible competitive antagonist. That just means it is progesterone at the progesterone receptor. And it said that they showed that if you add high concentrations of progesterone to the system, to the woman's body, it will reverse the binding of mifepristone. And AAPLOG, the American College of OBGYNs, they are an active opponent of abortion pill reversal. And yet they even acknowledged in their own documents that progesterone decreases the efficacy or the ability of mifepristone to cause an abortion. Now, they say in that document that abortion pill rescue is junk science and that we should not be recommending it to our patients. But if you look later in that document, it's talking about contraception, birth control, at the time of a woman doing a chemical abortion. And they specifically say that you should avoid giving a woman the birth control shot, Depo-Provera, at the time that she's doing a chemical abortion. Now, Depo-Provera is a large dose of progesterone. It's a different kind of progesterone than we use for APR, but it's progesterone. And the reason they say to avoid it is because it will, and I quote, increase the risk of ongoing pregnancy, meaning it decreases the effectiveness of mifepristone at ending that preborn child's life. So they acknowledge, without saying it in so many words, that progesterone is effective in counteracting the effects of mifepristone. All right, so let's talk a little bit about where it comes from. So it was first documented in 2011, although there was it was done in 2009 by Dr. Matthew Harrison, but basically around the same time, Dr. Harrison and Dr. Delgado on opposite coasts had patients coming to them who had started the abortion pill process and changed their minds. And again, we know that this happens not infrequently. And so they thought about how mifepristone worked. They thought about their knowledge of basic biochemistry, and they surmised that most likely progesterone would work to counteract the effects. And so they began offering that to their patients. The first case series was published by Dr. Delgado in 2012. It was very small. It was just 6 patients. But out of those 6 patients, 4 of them successfully continued their pregnancies to delivery. And that's how the abortion pill reversal or rescue network began. But they recognized that a larger study was needed to see if this was truly going to be beneficial for women. And so then in 2018, Dr. Delgado, along with his colleagues, published an observational case series of over 700 patients. And about 550 of them were available for the final analysis. And what they showed, now in this study, women received progesterone in a few different forms, either intramuscular, oral or by mouth, or vaginal use of progesterone. What they found was that the 2 most effective regimens, the regimen of 64, or the intramuscular regimen, ongoing pregnancy occurred in 64% of women, where they were able to carry their babies to term. With the high dose oral regimen, 68% of women carried to term. And you can see there that the vaginal dosing was much less effective. Now, you might say, yes, but what if you don't do anything? So what if a woman takes mifepristone, but doesn't take misoprostol, but also doesn't take progesterone? Does her baby survive in that case? Well, that actually had been looked at in previous studies. And so they looked at previous studies where women did not take that second drug. And what they found was at most 25% of them had ongoing pregnancies after taking mifepristone alone. Now, that was one study that had that high of a survival rate. Most of the studies were more like 10 to 13, 15%. So you can see that by giving progesterone, we increase the chance that a baby will survive from at most 25%, but again, probably less likely than that, up to nearly 70% when we use the high dose oral regimen, which is what we are currently using as part of the protocol. They also found no increased risk of birth defects in babies related to mifepristone exposure before the progesterone was taken. No increased risk of preterm birth. In fact, the babies in this study had a lower rate of preterm birth than the general population did. And no adverse outcomes to pregnancies were documented, no increase over the general population. So one of the common claims by opponents of APR is that this is experimental. Well, again, it involves giving progesterone and looking at the manufacturer's own studies that should work. But is progesterone experimental, as is claimed? It's not actually. So we've been using it safely for decades in the practice of obstetrics. In fact, infertility specialists for women who conceived as a result of IVF or women that have a history of recurrent first trimester miscarriages have been using natural progesterone for decades, and it is considered safe in pregnancy. The doses being used for APR are very similar to the doses being used in assisted reproductive technology patients or IVF patients or patients with recurrent pregnancy loss. And the safety of progesterone, natural progesterone in early pregnancy, is actually supported by the American Society for Reproductive Medicine, who have clearly stated that natural progesterone is safe in the first trimester of pregnancy, both for mom and for baby. And in fact, the FDA agreed with them. So this is not an experimental drug. But what about claims that APR is unsafe? I'm sure many of you have heard that. Well, this claim is based on one study. It was the only randomized controlled trial that's been done looking at abortion pill reversal. It was done by an abortionist named Mitchell Kreinen, who is in California. And the study was stopped early due to safety concerns. So the design of the study was that women came who wanted abortions. They knew they were going to have abortions, and they were given mifepristone first, and then after that, they were given either progesterone or a placebo and not given the second drug, misoprostol. Then they came back 2 weeks later and had an ultrasound. And if they still had a living fetus and their pregnancy was ongoing, then they would have a surgical abortion to complete their abortion, was how the study was designed. Well, it was stopped early after only 12 women were enrolled, but only 10 women were available for the final analysis. So there were 5 women in the group that received progesterone and 5 women in the group that received placebo. So it's a very small study, so you can't really draw significant conclusions from it. But what it showed, and again, remember, this is the study that's being used to claim that APR doesn't work and that it's unsafe. What it showed is that in the women who received progesterone, when they came back for that 2-week follow-up, 4 out of 5 of them had ongoing pregnancy. So APR worked at an 80% survival rate. In the placebo group, the women who did not receive progesterone, only 2 out of the 5 had ongoing pregnancy. So only a 40% survival rate. So even though the study is small, it showed that progesterone doubled the rate of survival of that preborn child. What were the safety concerns? Were they due to progesterone, as Dr. Kreinen claimed in his conclusions of the study? Well, no, they stopped it because 3 women had to go to the emergency room. One of those women was from the progesterone group, and 2 of those women were from the placebo group. The woman from the progesterone group, so again, this would have been who received abortion pill reversal, she went to the emergency room, was found to be completing her abortion, required no intervention, no treatment whatsoever, and she was sent home with no treatment. The 2 that went to the emergency room from the placebo group, so they did not get progesterone, they had only taken mifepristone. Both of them had to have emergency surgery. One of them had to have a blood transfusion, be admitted to the hospital. So the safety concerns didn't come from women getting progesterone. They came actually from the mifepristone. And those, again, are complications that we know are related to mifepristone, hemorrhage, retained tissue, the need for emergency surgery. So what this showed was progesterone actually alleviated those risks with mifepristone and actually was safer than mifepristone. And yet this study is quoted over and over and over again by opponents of APR, stating that this shows that it's unsafe. So how does the APR network work? Well, it's a 24-hour hotline that now is run by Heartbeat International. It is staffed around the clock by nurses who are well-trained in how to evaluate the patient for appropriateness. So a woman calls the hotline and she talks to a nurse who begins to ask her questions like, when did she take the first pill? Has she taken the second pill? Is she experiencing any symptoms like heavy bleeding or pain? If she is, she's instructed to go and be seen for medical care immediately. If she's not having that, they talk to her about what abortion pill reversal is, about the medication that she would take, possible side effects of the medication, and then ask her if she would like to talk to a physician about it or another prescriber. And again, I think it's important to know women are not forced into this decision. Many women call the network and then for whatever reason decide not to go ahead with abortion pill reversal. So no one is forced or coerced into making this decision to start this. Also, they are not told that it's going to be 100%. They are told very clearly what the statistics are. So they're not given unrealistic expectations. If she wants to go ahead with it, then she's connected by the APR network nurse to a physician or another prescriber in her area, who then calls the patient back, again, talks to the patient about, is this what she wants to do, what symptoms she's experiencing, and goes through a fully informed consent process with her. I will say that consent process is much more thorough than the consent process that most women are given when they start the chemical abortion process. Their pregnancy outcomes are then tracked and submitted to the APR network if they decide to go ahead with it, so that we can continue to follow their outcomes. They also then are seen in the office within 24 to 48 hours so that they can have an ultrasound to see whether or not their baby is still alive. So I'll just tell you a little bit about my APR experience. I'm not alone in this. The APR network now has more than 4,000 successful reversals. There's over 1,000 providers of APR across the country. But I'll just tell you from my experience of talking to women, it seems to be a common thread in that they found themselves in a moment of crisis, more than a moment. They found themselves in a crisis pregnancy, not knowing what to do, feeling very alone, very unsupported. And all they could think about was just this crisis that they were in. And so then they made the choice to go ahead and start an abortion. And every one of them that I talked to has said the minute she swallowed the pill or the minute she walked out of the abortion clinic, she knew that she'd made the wrong choice. It was like all of a sudden she could think straight again. And she realized, oh my goodness, what did I just do? And I want to save my baby. Thankfully, I've had a few successful reversals. I got to deliver one of those babies. It was the most wonderful delivery. And I'll just tell you, one of my recent patients who's actually due very soon, has texted me several times saying how thankful she was for the Abortion Pill Reversal Network. And she doesn't know what she would have done had that not been available. She doesn't know how she would have lived with herself, had she not been able to save her baby girl. And again, she made the decision out of desperation because the father of the baby was not supportive of her and she had no idea how she was going to be able to make it. Once she stepped back and realized that she had the support that she needed, then she desperately wanted to save her baby. And this is, again, a very common theme that we hear from women who call the network. You know, to me, the beautiful thing about abortion pill reversal is it saves a mom the grief of losing her child through abortion, if it's successful. But even if it's not, I think at least she knows she tried. This is a beautiful sculpture by an artist in Poland called Memorial to the Unborn Child. And it just shows the grief that we know many, many women feel even years later over the loss of the child that should have been. And the beauty of abortion pill reversal is that we can spare some women this lifetime of grief and instead allow her to have a lifetime of memories with her child. And again, regardless of where someone stands on the issue of abortion, why on earth would we want to deny a woman the chance to have a life with her child when she so desperately wants it? And so that's one of the many reasons why AAPLOG is proud to support abortion pill reversal and why we are so passionate about getting the evidence out there, because again, it really is overwhelming. I didn't have time to get into all of it, but there's a lot of good evidence out there, and you can find more of that at our website. I know Massachusetts Citizens for Life has a lot of resources to this as well. There's a video, if you don't mind listening to me talk for a little bit longer, there's a video on our website here of me debunking the top myths about abortion pill reversal and going into a little bit more detail about why they're not true. But we also need more APR providers. So if any of you know medical professionals who might be willing to be providers, again, they can go to this website to find out the evidence and also to sign up to be an APR provider. Many women, when they call in through the network, are having to go 2 hours to someone who can provide this for them. So we really need there to be many, many more physicians and other prescribers that are offering this to women in their area. And this is just a little bit more about AAPLOG, that, one of our main things is that we support women receiving fully informed consent. which not only includes being informed about the many detrimental effects of abortion, but also being informed about abortion pill reversal. We also feel very strongly that abortion is not healthcare, as evidenced by the fact that more than 90% of OBGYNs do not perform abortions. And yet we are women's healthcare specialists. If this was beneficial for our patients, everyone would be performing them, but most OBGYNs do not. And it's effective. I always just love the chance to share this. So this was a attempted hit piece written on us by Mother Jones, which is a very left-leaning outlet. And they came up with the title, but honestly, we always joke that we couldn't have come up with the better one ourselves. So it said they're doctors and they're also incredibly effective and dangerous anti-abortion activists. We believe that by getting the medical evidence out there about abortion's impact on women, that we can actually be effective in changing people's hearts and minds about the issue of abortion. So here's just some more resources for you, and hopefully this can be shared with y'all later. Again, our website is a great resource. The Alliance Defending Freedom website you can go to learn more about our lawsuit against the FDA over mifepristone. And then, of course, the APR website, abortionpillreversal.com. And then Massachusetts Citizens for Life, again, also has a lot of resources. So with that, I'm going to stop talking. I think I went a little bit over my time, but
Okay.
I'm going to stop sharing.
That was fantastic. Thank you so much. We do want to open it up to questions. If you have any questions at the bottom of the screen, you can just type it in, and then I'll relay that question to Dr. Francis. We did have one comment that someone, while you were speaking, saying that My Pregnancy Help Center has saved 5 babies so far with APR, which is wonderful,
amazing.
wonderful to
That's
read.
such
It's
great
fantastic.
news. Yeah, and thank you guys for providing it too. As I said, we need so many more people to be doing it so women have access to it close to where they are. So thank you for that.
Well, one of the questions related to that, we may have physicians that are listening. How time consuming and complicated is it for a physician to provide APR?
Yeah, well, so if you are already providing prenatal care to women, this will be honestly like a blip on your radar. The Abortion Pill Reversal Network has such a smooth system set up. So how it works, again, for me, is I'll get a text message to my phone that says, Dr. Francis, we have a woman in your area who wants to start APR. Are you available? And then, I just reach back out to them immediately. Then they call me, they give me some background on the patient. They give me the patient's name, her date of birth, her phone number, her pharmacy, the phone number of the pharmacy so that I can get the progesterone called in for her immediately. They will text you the protocol. In case it's been a while. The last time I did it, it had been a while since I'd done it. And I said, hey, can you remind me of the exact protocol again? So they'll do all of that for you. They provide all of that for you. And then you call the patient. So honestly, the biggest time investment is just that initial phone consultation with the patient, because I like to spend a lot of time with them to be sure that they understand everything. To talk to them about, the risks, benefits, all of that, and then get them started on the medication. And then again, if you have an office, so I work as a hospitalist, so I don't have an office anymore. So I get them tied in with an OB in the practice where I work, who can see them in the office within 24 to 48 hours. But if you've already got an office where you've got ultrasound capabilities and you're providing prenatal care, or if you can have that kind of arrangement with someone who does, then again, after that, it's essentially just like providing normal prenatal care services. I like to have them come back for frequent ultrasounds just because I think it makes everybody feel better for the first few weeks, but that's not required by the network. And I should have mentioned in my presentation, and I didn't. The minimum that we provide the progesterone for is 2 weeks, but I think most of us go through about 11 weeks of pregnancy with the progesterone. Just because then that's when the placenta starts taking over progesterone production.
Okay, great. And questions are definitely coming in. So one of the questions was, how fast do women need to take progesterone after taking the RU46? Important question.
Yeah, very important question. So the sooner the better, but the effectiveness, of progesterone is going to be significantly less if they take it more than 72 hours or 3 days after having taken the mifepristone. So it really is recommended that she get started within that first 3 days. But again, the success rates are higher the sooner she starts. So if you are talking to her 8 hours after she took the mifepristone, she should get started on it right away, because that's going to increase her baby's chances of survival.
Okay, great. Thank you. Next is, why is APR accepted in some states and not in others? Why do some states, such as Colorado, specifically ban APR? Is this really all about politics?
That is a great question. I think it's a good question we should all be asking our states if they're not allowing this. I think Colorado was the first state to actively go after anyone who's providing APR and threatening their licensure. California is doing the same thing. And I think I've heard, Paul, you might be able to tell me, wasn't Massachusetts maybe talking about doing the same thing? Or there was one of the New England states that was talking about it that I could.
We haven't done that yet, but we're just assuming they're watching Colorado and California.
Yeah. So it is a very good question. It really is all about politics. And, I've really tried for myself to figure out, why are people so opposed to abortion pill reversal, when again, nobody's being forced to do it. This is about giving women this option if they want to save their babies. But I think it's twofold. I think one, that it makes people admit that there's something there to be saved. So it really brings out the humanity of that preborn child, because why would you want to save that child if it's not a human being? And so one, I think it forces people to acknowledge the humanity of that preborn child. But two, it forces people to acknowledge that women regret their abortion choice, that it's not empowering to them. And we know that this happens all the time. And as the FDA lifted those regulations on mifepristone and women are now getting them online, they're getting even less counseling before they start the process. And so we're actually seeing the calls to the APR network increase, which is not surprising to me, because women are making this choice without really thinking about it now, without having appropriate counseling, and then regretting that decision at a higher rate. So and the other thing is that these states are fueled by the fact that a professional medical organization like in ACOG, the American College of OBGYNs, has said that this is an unsafe practice. And so they're using that then as justification for banning this in their states. And so that's another reason why it's really important that the actual evidence be out there that this is safe and that it works.
I guess one of the questions is, why is the pro-abortion side so aggressive, going after not only the science, but going after the clinicians, making it illegal in Colorado to even market it, let alone prescribe it? So what's at the heart of this, you think? Because it's more than just, physicians disagreeing about numbers. It's much more than that.
Yeah, absolutely. Well, I think that they rightly recognize that if abortion pill reversal becomes accepted practice, and it's something that we can openly talk about, that gets to the heart of their money-making industry. It really does. This is a way that I think hearts and minds will be changed when you see that women regret their choice and that they have the ability to save their child's life. And then you see that precious child who's only alive because of abortion pill reversal. That gets at the heart of their money-making industry, which, make no mistake, that's what the abortion industry is about. They're not about helping women. They're about making money. And this gets at the heart of that. And so I really do think that that's why, again, I'm talking about abortion activists here. That's why they are so vehemently against this. For many physicians just don't know that this exists. And so they need to understand that this exists. And all they hear is ACOG saying, well, it's junk science and it hurts women. So then I think a lot of physicians, well, then why would I do it? But when we talk about abortion activists being opposed to this, I really think that money is at the root of it. And honestly, if this succeeds with, being accepted, abortion pill rescue, it gets at the foundation of their industry, and and I think it will cause it to crumble. And they recognize that. I think they know that this has the ability to pull at the heartstrings of even people who might consider themselves supporters of abortion rights. But it's a reasonable thing. Again, even if somebody's pro-abortion, why would they want to deny this choice to women? So it has the ability to sort of reach across the aisle too, I think, when it comes to the abortion issue. And so that's very dangerous.
Yeah, you would think just at first blush, it's a win-win, whether you're pro-life, pro-abortion, it's giving women more choice, but that's not really how it's being really treated. And And you really touching upon the fact that, progesterone, inexpensive, widely available, is really an antidote to the Mifeprex.
Mhm.
And so if you're selling Mifeprex, why do you want that?
Right.
Right.
Exactly.
There was someone that works at a pregnancy resource center, and they're wondering how can they want to add that service? Like, what should they do? How do they get started there? What should happen?
Yeah, absolutely. Well, so again, if you go to our website, the applog.org/APR, and scroll down to the bottom of that abortion pill reversal page, there's a link that you can click on to become a provider of abortion pill reversal. And many pregnancy centers are. You just need to have a medical director. You've got to have somebody that the prescription can be dispensed under. And then you can talk to the Abortion Pill Reversal Network about getting signed up and being with them. And then the other thing, and again, if you are providing any kind of medical services, I'm sure that you have insurance coverage, and so you definitely just want to check with your insurance carrier as well about insurance coverage for that. But it should cover it. So yeah, it's really actually a very easy process. They walk you through the protocol, they walk you through the appropriate intake questions, all of that. But I think pregnancy centers are a great first point of contact for women for abortion pill reversal, because you can get them in to get an ultrasound. You can see them at least initially, and then get them tied into an OB-GYN in their area.
Right. Thank you for that. One of the questions is, how did you first learn about APR?
Yeah, great question. It was actually at an AAPLOG conference. So Dr. Delgado, who's one of the founders of APR, is still actually one of our board members. And one of my very first AAPLOG conferences that I went to, he gave a presentation on abortion pill reversal, and then had a table set up for people to sign up to be providers in the network. And so I signed up then, and within I think it was within a few months of that, actually had my first call, my very first patient that I did abortion pill reversal on. So so that's how I got started with that.
And then there's a question, I think it's related back to Dr. Crennan's study of the 10 women. They were confused by the placebo testing. They were wondering, how were these volunteers chosen, and why were some given placebo? And I think they were getting into sort of the ethics of that.
Yeah. Well, it's a great question, because it's why. So one of the biggest accusations, I suppose, against APR is that we don't have any randomized controlled trials. That Dr. Delgado's study was an observational case series. But the reason that those of us who believe that life is valuable and worthy of saving don't do a randomized controlled trial is because it would be unethical to give a placebo to a woman who wants to save her baby when we know that progesterone works. So this was an attempt at doing a randomized controlled trial. But again, I mean, it sounds very callous, but it is the way that some medical trials are done. But because these women they were coming to an abortion facility to have an abortion, their intention was never to save the life of their child. They were going to have an abortion one way or another. And so they were recruited then based on that, and told, I presume that they were ethical in how they told the women about the study. But just was that, if your baby then is still alive when you come back 2 weeks later, then you'll have a surgical completion of your abortion. So then they were randomized to either receive a placebo or progesterone. That's the way randomized controlled trials are done, so that we can compare, is the treatment method actually better than just a placebo or a sugar pill? So the question is very spot on, in that it is unethical actually to give a placebo, but they were doing it because they were at an abortion facility where women were determined to have an abortion, regardless. So,
Two questions kind of related. How much does a progesterone cost, and does insurance cover APR?
So it depends on the insurance carrier. Some of them will, some of them won't. The good thing is, so some pregnancy centers have decided to keep some of this in stock so that they can help, or they help women with the cost. Actually, what I found to be super helpful is some of you might know about prescription discount coupons, like through a website called GoodRx. There's several that you can use. In my area, I usually can find a deal through GoodRx for them if they don't have insurance coverage, that we can usually get it for about $20 for a month's supply. So, they typically will only need to use it for, about a month at the most. So, you're looking at about $20 even if they don't have insurance coverage at all. So it's very affordable. Certainly much less than what they've paid for their chemical abortion, but very affordable. And again, I know a lot of centers have protocols in place for how they might be able to help, because certainly we wouldn't want a woman to lose her child's life just because she didn't have $20 or $30 to spend on progesterone. So, but it can be done. I mean, I can't even tell you how many times I've sat down at my home computer and I've said, okay, let me see what I can find you, and then texted her the coupon. Here's the coupon, take this into your pharmacy. So very easy to find that, and carried by most pharmacies. So it doesn't have to be specially compounded or anything like that. So very easy to find.
Right. This is a question related to Dr. Delgado's 2018 study. Did any of the women who received APR end up in the emergency room?
Not that was reported, but that wasn't necessarily tracked for all women. So some women had their outcomes reported as far as whether or not they went to the emergency room, but that was not specifically tracked. There is another study that is in development right now that will be looking at that. So.
And another question about cost, but this is on the flip side. How much does a chemical abortion cost to get the mifeprix and the mifepristone to get a kit?
Yeah, I think it kind of depends on where you're at, but the price range that I've heard for women is typically anywhere between about $400 and $800. When they order them online, I think they can get them for maybe $200. It might be a little bit cheaper online, but still you're looking at well over $100 for sure. But through abortion facility, brick and mortar abortion facilities, typically they were running anywhere from $400 to $800 were costs that I heard. And again, I think just kind of depending on what part of the country that you're in.
Right. And I think, the Charlotte Lozier Institute had done a study. It's a bit old on all the websites now that are offering it. And the prices have definitely, come down for that.
Yeah.
Related to women who, go in for abortion pill reversal and take their progesterone, how long do they just take the pill? Once, twice, several weeks? I mean, can you give a sense of what's involved for the patient? What do they actually have to do?
Yeah. So for the first 3 days, they take it twice a day. So they take a morning dose and an evening dose. And then after that, they just take it at night. And again, they need to do it for a minimum of 2 weeks. But I typically have continued it until about 11 weeks, because then at that point, at the end of the 11th week is when the placenta is fully developed and takes over progesterone production. So very easy. Side effects are pretty minimal. Sometimes women get a little bit nauseated, a little bit bloated, but other than that, typically they won't experience much as far as side effects go.
Okay. Well, I think we're just about at the top of the hour. I guess one last question, which is, what needs to be done here to sort of spread the word about APR?
Yeah, well, I think just having a conversation about it, no matter where you're at, because you never know when you might be interacting either with a woman who might be contemplating an abortion via these drugs, or with someone who maybe their child is contemplating that. So I think, again, time is of the essence with this. So people just knowing that this is a possibility even before they make the choice to have an abortion. Also, maybe talking about it will help a woman think twice about even starting a chemical abortion. I mean, I think that's also very possible. So I think spreading the word just in your general conversations, people are often amazed to hear that it exists. So it's something that, oftentimes in this discussion around abortion, those can be really hard conversations to have and hard topics to address. But this is a really cool thing to talk about. It's a really neat thing to talk about, that women have the opportunity to save their babies. So maybe it's a little bit easier to talk about. But then I think arming ourselves with, and again, with all the resources that we've listed, you can do that. Arming yourself with good responses to the arguments against abortion pill reversal too, so that we can help people to understand that there is a lot of evidence to support this. And talking to, either your local legislators or talking to your physician. If you're going to see an OBGYN, I'd ask him, hey, do you know about abortion pill reversal? Just in case you have a patient who wants it, because again, we need people to know about this, whether they're pro-life or pro-abortion, they should know about this and they should be able to provide it for their patients.
Right. Well, we're at the top of the hour, so we just want to bring it to a close. Thank you so much. It was really informative, really interesting, really enjoyed it. Thank you so much for sharing your expertise with everyone. And thank you for everyone who connected and stayed listening to the very end. Please respond to the survey. It's how we know that we're, hitting the mark and doing the right thing. So thank you very much, Dr. Francis.
Thank you. Thank you for having me.
All right. Good evening.